AI and cloud technology will for sure help us and the physicians that come after us in the future. But to start off with, the cider technology is a tool that we use in theater to have a very nice and bright look on, for example, where the side branches of the aorta are. And since the system is a learning system, a self-learning system, and even a deep learning system, in the future I expect to get feedback from the system. But now it's a very straightforward tool that helps in straightforward cases like normal EVAR cases, but also for the more complex fenestrated and branch cases. So I expect something from AI, but mainly in the future, and we'll see where it takes us.
Yeah, and like Jan, we're a big, busy academic centre, and we currently have obviously a hybrid theatre, and we routinely do image fusion and 3D planning. Unlike Jan, at this stage, we're not utilising SIDAR. But in terms of the cloud-based application, I think initially there's the obvious application that you can get that kind of level of image overlay and planning cloud-based, independent of the quality of the equipment that you're currently using. That's obviously a huge attraction to not so much an academic centre like ours, but many others. But as Jan suggested, the future with this ongoing learning, but also the ability to apply it to planning and follow-up is huge. And I think that's going to be a real value for this technology. Well, yeah, I'll start and then get Jan to comment. But I mean, we find that there amongst physicians, there's a lot of variability in terms of decision making based on, let's say, endograft sizing, diameters, lengths, the choice of graft for the same anatomy. You could look at a number of leading physicians with a lot of experience, and they'll take different approaches. And while some of that is evidence based, I think we're not having the opportunity to learn from previous outcomes to optimize that kind of learning. So, things like diameter of graft, supra or infrarenal fixation, limb lengths and diameters. There are many things that we could be learning from past experience, which would mean that there is a more reproducible and optimized planning of endografts.
Yeah, I think I couldn't agree more. That what we've learned in the past, so to speak, the past will help the future. And now everybody has his own way of planning. There are, of course, supporting technologies to do your endografting planning, but it is comes in very handy if it is all in one platform. And I think that's one of the pros that the CIDR technology brings. So you can do the planning, you have your procedure itself, and then you have afterwards the feedback of how you did perform. And I think down the road that will help us, and therefore the less skilled endovascular specialists will have the past to help them to perform in the near future, and not just because I was trained by very good professionals, and for sure you are, and we're skilled endovascular specialists right now, and you stand on the shoulders, so to speak, of the people that taught you. But this system is like an input of thousands of procedures that will help you selecting, recognizing what the pitfalls of a procedure will be, looking for things like proximal and distal seal. So this system for sure will help us improving outcome. We had an overlay system as well. We have hybrid theaters, and before we had, of course, mobile C-arms. The CIDR system is running on mobile as well as it is in hybrid theaters. And one of the pros is comparing it to a more rigid overlaying system is that there is a real plasticity of the anatomy. So we all know that as soon as you introduce stent graft or wires, the anatomy changes. And if you then do the angio run and you have a static overlay system, it pretty much is, you can have, for example, the renals being online, but distally the aortic bifurcation is directly going offline. because of the change anatomy. And the CIDR offers you a, let's say, perfect one-to-one overlay, because you can adapt it yourself with the remote control. So that comes in very, very helpful.
And I see that, along with the optimized planning that we were talking about, I see this as a huge advantage. We know that we're starting to appreciate that our ability at the end of the procedure, and even at the first CT, to predict people with good outcomes is improving with collective knowledge. And we know that there is a group of patients that, based on the final completion angiography and the first CT, really will require minimum surveillance over a long period of time and are highly unlikely to need a re-intervention or have aneurysm-related problems. But there's another group of people who we need much more intense surveillance. Now, academic centres probably are more aware of that data than non-academic centres, but what we're trying to do, what I think this is really offering, is you're not subjecting some cohorts of patients to learning curves within experienced centres or low volume centres. You can get much more uniform decision making. So, the prospect of this is that you'll get data that we can all agree on that will say, hey, listen, you've got 10 millimeters or 15 millimeters of proximal seal in a neck of this diameter. The likelihood of you to have a subsequent proximal neck issue is very, very low, and that will impact on what surveillance you need to do and how often. That's a huge step forward if you think about the amount of time that patient, or the radiation exposure, and even the amount of time patients having to come backwards and forwards for clinic visits and imaging. We can definitely do it better, and I think this automated learning is a real step forward here. I don't know if you agree about that.
Yeah, I fully agree. And once you're skilled, you know what the pitfalls are, so to speak. But if the system helps you defining where pitfalls are, like for the short, wide, angulated or conical necks, which we're all aware of, that's an issue. If the system comes in and say, well, you have this narrow iliac axis, be aware of it, or you have a very highly angulated neck, and if you want to go for a proper seal, take that into account. So yeah, I agree very much with you, Andrew. And I think we're pretty much aware of, let's say, looking at a patient with a short, wide, angulated or conical neck, or an iliac axis that is very narrow. That's, for us, it's, we've been there. But if the system can help less experienced or starting endovascular specialists, and the system can simply point out, okay, this is a patient where you should be aware of the neck, or you should be aware of the iliac axis, that helps in getting better. And for sure, the system will do that in the future, just on the basis of what it put into the cloud. Well, for example, I think CIDR is working on supporting where, for example, if you want to aim for a proper seal in the infrarenal neck, and let's say you have an 11 millimeter infrarenal neck, we kind of say it is possible with certain devices because a 10 millimeter seal is enough. But it's not just the seal and the length, but it is where you end up with your stent graft. So indicating upfront when doing planning and having a circle indicating, well, your device should start here if you want to reach this, let's say, 10 or 11 millimeter seal. Even for skilled endovascular surgeons, I think it comes in very helpful because it delineates where you should start with your endovascular device.
Yeah.
So even with skilled physicians, I think it will be helpful.
I agree, and I think if you think about what we're dealing with, the combination of a huge volume of experience, that most clinicians would say, well, even if it's conformational on the decisions I want to make, I'd like to know it. So I think putting the patient first, if there's anything they can do to improve outcomes, most physicians would say, well, I want to embrace this. Egos aside, you're going to learn something from thousands of cases experience. Many of us have done 1,000 EVAR cases, but not 10 or 20,000 cases. Personally, I think it basically will then correlate with their own clinical experience. So if they are following guidelines, both with planning and with follow-up, and their outcomes are satisfactory, either the same or better than what they've been able to achieve, that will be confirmational. I don't see why that wouldn't happen that way. So I think obviously there'll be initially people wanting to make sure that this confirms the decisions they would otherwise make. But I think in time, as people build up good experience, that will build up confidence.
Yeah, for sure. And it takes quite some time to become a skilled endovascular specialist. So the system probably will help you having a steeper learning curve on the basis of all the procedures being done before. And in general, you could say the more you dump things down, so to speak, the better it is, because it's the patient we're all doing it for. Well, again, these are the critical things we're looking at. If you decide to do a straightforward EVAR or a fenestrated or branch case, a very highly thrombosed infrarenal neck we know it's not good for seal. So if you have a system just looking along with you, pointing out the critical points of this particular aorta, that will very much be very helpful.
I think it's vital. I just give an example of a conical neck. So you think of a conical neck, and you say, "Look, I want to get 10 to 20% oversizing with my proximal graft." But am I talking about in the immediate infrarenal segment, in the mid portion of the neck, and the distal portion of the neck? As I mentioned, there is some good data on outcome data now that I know CIDR will be utilizing that shows exactly how you should oversize a conical neck and answer that question. But you will find clinicians vary in their approach, and they may well not be aware of that data. So I think, as we've said before, what it's going to do is provide much more uniform decision making, independent of experience, which should translate to better outcomes. And I think the proof will be in the pudding. It'll need validation, but the potential is no doubt there to improve outcomes because of better decision making.
Which reminds me, Andrew, we recently had a discussion on endoleaks, and you just pointed out that if you have, for example, a polar renal artery and an AMI of 4 millimeters, you stated you have like 100% endoleak. So if you put that kind of knowledge into a system that probably not everyone is aware of these data, that will be very helpful as well. So the support of big data and simply supporting you on the basis of the data, supporting you with the decisions you make.
Absolutely. I think that'll depend geographically. There'll be different requirements and different principles there. But I think acquiring anonymized data obviously requires patient consent. But essentially, in my experience, patients are delighted to provide anonymized data if they think this will contribute to better outcomes for them, but more importantly for other people in the future. I always get that comment when we're doing trial work. Look, if it helps me, that's great, but if it helps others, that's even better. And this definitely will. And it's not a huge impost on patients to say, would you mind if we share anonymized data that will help global learning on how to do this procedure better? Most patients would be delighted to do that. So that would be how we would have to do that. But I think it won't be a big barrier.
Yeah, I fully agree that patients are very willing to help. in general for their own procedure, of course, but also for the benefit of others. And then again, the system and CIDR must be so good to speak that there is no doubt about how safe it is and how ethical it is organized. So it should be organized extremely well. And I think hospitals need that confirmation too. Not only patients, also physicians need that confirmation, and hospitals as well. But I think you organize it like it should be.
They may be sensitive about that, but if I can speak personally, if you're confident in that you're practicing at a sort of reasonably good evidence-based level, then you'd welcome sharing your experience. And so, I'd be disappointed if that was I think it's basically if the patient is happy to, and let's remember that we all learn a lot more from cases that don't go well than cases that do. So we don't always have to nail it every case for that information to be very valuable to artificial learning programs that CIDR would use. So hopefully that's not a big issue. I don't know what you think.
No, I fully agree that you learn the most from your own failures and the failures of others. I don't think it will be embraced if you can compare Andrew Holden's data and my data, because he's so much better than I am. That would be very painful. No, just kidding. But I don't think you should have a one-on-one comparison between hospitals or physicians. You should stay away from that. So it should be anonymized. But if there is a case, let's say we have like 20,000 cases in the system, and one of us is treating a very challenging patient, and the system picks out, let's say, 800 similar cases, and they all have like real issues they run into, and the system, it kind of warns you, this is an extreme challenging case, be aware of what these 800 cases taught the system. That would be fantastic, but it shouldn't go back to one physician or whatsoever.
Yeah. And we already we do that in a very, I may well have a tricky case and share it with Jan and say, what would you do in this case? But this allows us to do that at a much greater level automatically. It's
Well, I think we should embrace AI platforms. That's my personal opinion. And don't forget, the AI is trained by not some foreign people from another planet. It's trained by us. So it is fantastic that the input that we can deliver will in some way create the future, so to speak. So it's important to have good data in, because if you put good data in, you get good data out. If you put rubbish in, you get rubbish out. So don't forget that a learning system is defined by the input you give. And I think it's extremely supportive in many ways if you can embrace AI technologies in general.
And I like the objectivity that provide for research. I'll give an example. Various EVAR devices, we look at the follow-up, and core labs will read out a type 2 endoleak rate, and you'll say, rubbish, I don't have that type 2 endoleak in my practice. But the objective data is that's what it is. It is what it is, and that's the good thing about AI, is that it's not being influenced or biased, and it's providing objective data that we can all contribute to. So I think it would be a real step forward and facilitate research, and probably make it opportunity for many more sites to get involved or contribute to important research because of the objectivity and the availability of AI.
And probably more transparent as well, because it doesn't. You don't like to admit that something went wrong, or too many times went wrong in your own practice. But if you have like an objective system looking at it, and not to punish you, so to speak, but to improve things and to learn, it's a very powerful thing. Well, I think I should answer that because Max Verstappen is the world champion the
Yeah.
second time now. So thank you for
Yeah,
bringing this up. Yeah, it's
painful.
bizarre what they do in Formula One. They have like more than 1 million data coming from the car within a second, and so they're not only planning the race, they're also analyzing the race during the procedure, and afterwards they analyze it. So that's I think a very good comparison of what SIDAR can bring. It is not just planning, but it's data that has been raced before, and they're not surprised that even if the tracks change, because they do. The system helps them to have the perfect curve and to do the perfect driving. So I like the analogy. Yeah.
Yeah, good on Max, although I'm a Lewis Hamilton fan. But I agree. I mean, I think one of the things you can see over the impact of this learning is in Formula One is that the cars are going faster, but overall safer. And so I think the analogy is that you've made is safety and efficacy. You know, if we can make the procedures safer and more efficacious by utilizing this information, just as happened in Formula One, that's got to be a good thing.